Welcome to Medical Logistics 101, Food Poisoning Patient Scenario. This video is for educational purposes only. It is not medical advice, does not replace a medical evaluation, and may not apply to your situation. If you have symptoms or concerns, please speak to a licensed healthcare professional. My goal is to help patients enter healthcare with a map instead of a blindfold, and to explain how clinicians think through these problems in resource-limited settings. Background story. 34-year-old male presents to the ED with acute onset vomiting, diarrhea, and abdominal cramping, beginning 8 hours after eating chicken salad from a local deli. No recent travel, no sick contacts, and no chronic medical conditions. Common organisms we would be worried about in this instance, Staphylococcus aureus. In this case, you have a preformed heat-stable toxin where you have rapid onset of vomiting, usually over 1 to 6 hours. Important point here, people associate Staphylococcus, of course, with skin infections, but it can also cause food poisoning. And in this instance, it produces a toxin that will already be in the food, such that if I cook the food at that point, kill the bacteria, the toxin still remains and can produce really severe symptoms rapidly. Bacillus cereus, associated with reheating rice, can be associated with emetic or diarrhea form for symptoms are concerned. Salmonella, of course, we associate that with poultry. Eggs, of course, I've seen it associated with ice cream. Um, Typically causes fever and diarrhea. Campylobacter, undercooked poultry, cramping, plus diarrhea. E. coli, certain strains, contaminated produce or beef, watery or bloody diarrhea. When we see bloody diarrhea, we think about Shigella. Listeria, associated with deli meats, soft cheeses, can pose a risk to pregnancy. Certainly have seen that in some national incidents of Listeria contaminating deli meats. And in the news lately, Cyclospora, associated with contaminated produce, watery diarrhea, severe fatigue, and last, norovirus, highly contagious, vomiting. Seen it multiple times with cruise ship outbreaks. Some of these cases, they remind me of back when I was in medical school with a microbiology class. Our professors obtained a number of chickens from around our local city, and we cultured almost on all of them Salmonella, Campylobacter, and E. coli. So it just really emphasizes the danger, particularly with poultry, cooking it properly. Regarding E. coli, I had a patient once. I can't recall why they were in the ER, but in addition to his normal workup, I was doing a complete metabolic panel, and he came back with his renal function was decreased. He wasn't in renal failure, but he had poor renal function. And I mentioned this to him, and he was certainly already aware of it. And he said, yes, that was bad lettuce. And we talked briefly about what had happened. And he was one of those individuals, if you recall, a number of years ago, I believe it was associated with a fast food chain, again, contaminated lettuce with a certain strain of E. coli. And he suffered sepsis and had renal injury from it. Signs and symptoms in this case, the patient has acute nausea and profuse vomiting, watery diarrhea, non-bloody, diffuse abdominal cramping, but no bloody stools, mild fever, 100.4, dry mucous membranes, tachycardia, heart rate of 110, no peritoneal signs, which would be an important finding, and no neurologic symptoms. Considerations given the 8-hour onset, vomiting, and deli chicken salad. The top considerations would be Staph aureus and Salmonella. Signs and symptoms favor toxin-mediated illness rather than invasive bacterial disease. Physical exam findings: mild dehydration, tachycardia, hyperactive bowel sounds, diffuse non-focal abdominal tenderness, no guarding or rebound, which would be a very important finding, capillary refill, slightly delayed, no rash, and no jaundice. Workup: most food poisoning cases are clinical diagnosis. Workup is guided by the severity. Labs I typically obtain a complete a CBC, a complete metabolic panel. CBC may show mild leukocytosis. CMP assesses dehydration, electrolyte status, and of course your liver function test. Sometimes I will obtain a lactic acid if there's severe dehydration or a concern for sepsis. And given some of the symptoms that patients will sometimes have with severe food poisoning, they could very well meet sepsis criteria. And of course a pregnancy test if it's applicable. Workup: imaging not typically needed unless you have severe pain, peritoneal signs, a concern for obstruction or ischemia. I've examined thousands of abdominal pain patients over the years, and you'll get a feel for, like I said, is this something that I need to really be worried about? Things such as appendicitis, pancreatitis, cholecystitis, diverticulitis, or bowel obstruction. If there's ever any doubt, certainly if they have any peritoneal signs of severe pain, I typically will get a CT of the abdomen and pelvis, preferably with contrast. Stool studies: only if there's red flags present, stool PCR, stool culture, and a C. difficile test if you have a history of recent antibiotic use. Treatment, supportive care is the mainstay. Oral or IV hydration, electrolyte replacement, antiemetics such as Zofran or ondansetron, antidiarrheals such as Lomotil, only if there's no fever or bloody stools. And I'm very careful about using Lomotil in these patients just because it can sometimes make them get worse over time. Antibiotics, limited role and not indicated for staph toxin or norovirus. Consider if there's suspected salmonella, campylobacter, or Shigella infection. Outcome, the patient receives 2 liters of IV fluids, ondansetron, oral rehydration plan. Symptoms improve significantly in the ED, and he's discharged home with instructions for hydration and return precautions. And that's an important discussion to have. Disposition, most patients can be discharged home if there's no comorbidities. Return precautions would be dehydration, obviously if you develop bloody stools, persistent fever, and the big one, of course, worsening pain. Expected recovery, vomiting usually resolves within 12 to 24 hours. Diarrhea usually resolves in 24 to 48 hours. I would expect typically full recovery in 2 to 3 days. In closing, if this is the kind of content you find helpful, please like and subscribe. If there are topics you would like to see covered, you can email me at medicallogistics101@gmail.com. Remember, the danger isn't always what you know, but rather what you can afford to miss. Thank you.